In Colorado, there is not a specific statute distinguishing domestic violence from physical assault or other crimes against a stranger. However, it is defined as an act or threatened act of violence against a person whom the defendant has an intimate relationship with, and the act is used to coerce, control, punish, intimidate, or seek revenge against that person. According to the CDC, in the US, more than 300,000 pregnant women experience some kind of violence involving an intimate partner. Domestic violence is the leading cause of injury to American women between the ages of 14 and 55, and it's estimated to be responsible for 20 to 25% of hospital ER visits by women. 4 to 8% of all women who experience domestic violence experience it during pregnancy, and this is often the time when it begins or escalates. Characteristics of women in abusive relationships can be hard to distinguish as it does not discriminate against any race, religion, social background, or age. However, they may appear passive or even helpless in attempts to reduce the violence as they try to survive day to day and are often socially isolated. Women who have identified their abusers may present as passive, hostile, anxious, depressed, or hysterical. And oftentimes, common beliefs that the victim holds are financial dependency on their significant other, being fearful of her life and her children. She may often believe that she is the cause of abuse. She may feel ashamed of the abuse, or she may believe that he will change. Common maternal complications during pregnancy that stem from domestic violence include depression, suicide, low weight gain, infections, substance abuse, hypertension and GI symptoms from stress, and STIs, UTIs, and genital trauma. Fetal complications can be low birth weight, preterm birth, fetal demise, premature separation of the placenta, and hemorrhages. Women of abuse may be reluctant to seek help as they may fear that they won't be believed, they have fear of escalated violence, or they are often called the silent women because they do not ask a lot of questions, and this is mistaken for compliance and adequate education. Studies have shown that domestic violence is a consistent and strong risk factor for unintended pregnancy and abortion across a variety of settings. Unintended pregnancy terminated through unsafe abortion practices can result in death and serious complications. By reducing domestic violence by 50%, we could potentially reduce unintended pregnancy by 2 to 18% and abortion by 4.5 to 40%.
Women who are at a higher risk of domestic violence are the socioeconomic lower classes and those who are uneducated. These groups of women are typically only seen in EDs, are financially more dependent on others, have fewer resources and support, and fewer problem-solving skills. Women with an education or women who are more financially stable may not, quote, fit the stereotype, unquote, of a domestic abuse victim, so they are often dismissed by healthcare providers and do not get the support that they need. Nurses are encouraged to assess for abuse in all women as we may be their only contact. Questions to ask include, do you feel safe at home or with your partner? What happens when your partner gets angry? Does fighting escalate physically? Nurses should normalize these questions by stating that many families have issues expressing anger and dealing with conflict. Nurses should be looking for evidence of power or control in the patient's relationships and should ask bluntly about the partner physically hurting the woman. Vague questions may confuse the patient. Questions such as, has your partner ever slapped, kicked, or hit you? Do you feel isolated? Has your partner forced you to have sex or participate in activities that make you uncomfortable? These questions leave no room for interpretation. Other cues about domestic violence include delay in seeking medical attention, missed appointments, vague explanations of injuries, nonspecific complaints, social isolation, lack of eye contact, the partner not wanting to leave the woman alone with the provider, substance abuse, anxiety, insomnia, self-directed abuse, and depression. As a nurse during assessment, look at the patient's breasts, face, abdomen, and buttocks. Physical signs to look for are multiple wounds and injuries at various stages of healing, ranging from minor to serious, and strange patterns of what was used, including teeth, utensils, and hot objects. It is important to know what the abuser may do or look like in a relationship such as this. The partner will seem controlling. They may be reluctant to let you see the patient alone, or they may not let the patient speak or make decisions, even when they are capable of doing so. A therapeutic relationship with patients and skillful interviewing will help women to disclose and describe their abuse. Language is extremely important when talking with these women. A major factor in addressing abuse is to identify the woman as a survivor, not a victim. The word victim suggests someone who is harmed, is made to suffer, and may have little or no control. Survivor is an empowering term that suggests coping and decision-making in relation to taking control of one's life. A skill or tool that nurses have that provides framework for sensitive nursing interventions is the ABCDEs of caring for the abused woman. First, reassuring her that she is not alone is extremely important, as the isolation by the abuser keeps her from knowing that others are in the same situation and that healthcare providers can help. Express belief that violence against the woman is not acceptable in any situation, and that it is not her fault. No one deserves to be hurt or mistreated. C, confidentiality is crucial, particularly because the woman may believe that if the abuse is reported, the perpetrator will retaliate. Descriptive D, documentation, includes the woman's quoted statement, not her subjective opinion, accurate descriptions of injuries, and a history of the first, worst, and most recent incident, and with the woman's consent, evidence, or photographs. E, education, especially that violence is likely to recur and escalate. Education about options, including community resources. Ask her if she knows how to obtain a restraining order. Finally, S, safety is the most significant part of the intervention because one of the most dangerous times for a woman is when she decides to leave. Challenges that nurses have with providing care for the domestic abuse population not only includes the direct physical or psychological impact on the pregnancy, mother, and baby, but the barriers to care for this population as well. Recognizing that many cases of domestic abuse start during pregnancy, nurses must consider how we can meet the needs of pregnant women who are experiencing abuse. Experience of domestic abuse often delays prenatal care in the pregnant woman, suggesting that adequate prenatal care is not achieved. Psychological support as well as handling the physical complications on the pregnancy need to be addressed. Nurses need to be educated on the signs and symptoms of domestic abuse. Maternity units should use universal screening for domestic abuse. Nurses should be trained to provide information to women about choices they have to protect themselves and their children, and where to go for help if domestic abuse is disclosed. We must offer an environment in which the pregnant woman feels safe and able to discuss her situation openly. Women delay care for reasons such as thinking nobody can alter their situation or help end the abuse, methodical and insensitive manner of screening, feeling their concerns are minimized and ignored, potential involvement with punitive actions by social services, and fear of repercussions from abusers, especially if the woman is accompanied to the appointment by her partner. Challenges on the nurse's side may include lack of training or information, lack of confidential time, not feeling like it is part of his or her role in the pregnancy, feelings of frustration with the judgment that the woman is passive in her situation, and concern with placing the pregnant woman at an increased risk with her abuser by intervening.